Thank you, Maureen. First of all, I want to thank the organizers of the conference for inviting me to speak. It's quite a privilege to be included in the faculty in which there are many folks whose literature and research informed my teaching and the research I did while I was an active member of the group at the University of Washington studying the medical, scientific, and policy issues surrounding genetics. I also want to acknowledge that the audience might be a little daunted at the prospect of listening to a lawyer right after lunch, particularly in a comfortable room with muted lighting, but fortunately for both of us, there's muted lighting, and I will try to make my talk as crisp and as interesting as possible. How are we going? And to start off, I'd like to borrow a case report that appears in the literature that was published by a group that included Dr. Wiley Burke, and Ben Wilfond, two of the contributors to this conference. And it involves a 55-year-old woman whose 85-year-old father is a BRCA1 mutation carrier. At the time of this case, the father was in good health, but his sister had died of ovarian cancer at age 35, and he was participating in an NCI study of familial breast and ovarian cancer, which is how he learned about his mutation status. He encouraged his children, including the proband, her two sisters who were age 40 and 48, and her brother, who is age 38, to participate in the study and to pursue testing. During pre-test genetic counseling, the proband clearly stated a preference that her test results not be shared with family members if they were positive, and that included her children. The proband and two of her siblings tested positive. It was one sister, one brother, and the proband. And these results were discussed with each of them in individual sessions. The proband was assured again that her preference to maintain confidentiality would be respected. Her siblings shared their results with family members. However, when it came time for the proband to talk, she chose to tell the family that her results were negative. The providers were aware of this deceit and also aware that the proband had children who shared the family risk for the BRCA1 mutation. Moreover, one of the children was a 23-year-old girl. She was approaching the age at which it was then generally recommended mutation carriers begin routine breast and ovarian cancer screening. This case clearly presented an ethical dilemma. There is a duty to maintain confidentiality. There is a corresponding duty to avoid harm, which could arguably include breaching confidentiality and reaching out to this 23-year-old daughter. So we're going to move now with this case study in mind to talk about what role would the law play in trying to resolve this dilemma. We're going to start off by talking a little bit, just briefly, about the legal concept of duty and how courts try to decide when providers in a situation like this might have a duty. We'll look at the literature and what has been said in the medical literature and scientific literature on this topic. We'll analyze the role of the law that is out there, the precedent, if you will, and end with some conclusions and recommendations. So there's a quote on the screen now that defines the concept of legal duty. And the important point about this quote is that when the courts sit down to decide whether or not to impose a duty, they look at established precedent, statutes, preceding case law. They also look at social policy and literature and evidence that would inform what people in the particular context are supposed to do in order to protect someone who might be at risk of harm resulting from their conduct. So they look at law, they look at policy, they look at literature. If we review the medical literature and the scientific literature, It certainly frames the debate around this issue regarding when or if or when do we have a duty to warn outside of the physician-patient context. And you'll see that there's a very small minority position that says providers never have a duty to warn. They never have a duty to breach confidentiality and go beyond what the patient's wishes are to warn a third party. There are many who believe that there is a privilege to warn provided the patient consents. And then there is a group of people in the literature who are advocating a very narrow duty to warn in a carefully defined set of circumstances that we will be reviewing. Certainly, the literature recognizes that this debate is framed by competing ethical conflicts, the duty of beneficence, the duty of justice, to provide no harm, to promote access to care, but also the duty to respect patient autonomy, a patient's confidentiality, preferences, a patient's desire, their right to make their own treatment decisions and determine what do they want to know and not know about their own health condition. This debate also recognizes legal conflicts, the conflicts between privacy and confidentiality on the one hand, and how the law defines the extent of those rights, and the concern about tort liability on the other hand. This concept that we can be sued for and we can be obligated to someone if we are negligent, if we fail to take action that is careful of other people's rights, if we fail to conduct ourselves in a way to protect others from harm. There is a consensus position in the literature, and it is that providers should generally try to counsel patients to inform potentially affected family members about their genetic risk. And you can see here the group of well-established professional organizations that have come down in favor of counseling patients to do the warning. The American Society of Human Genetics, the Institute of Medicine, and the President's Commission, however, do recognize that providers may have a duty to warn in a very narrowly defined set of circumstances, and by that I mean to breach confidentiality and warn family members. And these would occur when patients harbor a genetic defect that is highly penetrant, and its expression is almost always associated with a very serious adverse health outcome. For example, Huntington's disease or FAP, two conditions that were discussed this morning. It also arises when an effective and time-sensitive intervention for the defect exists. So you have a highly penetrant condition with serious expression and an effective time-sensitive intervention for the defect exists. That might be FAP, but not Huntington's disease. And you have this situation where the patient refuses to tell potentially affected family members that are identifiable to the provider. Now, the courts would also look to available data regarding what do patients think about this? Do they feel that providers should have a duty to warn? And here are a few of the limited number of studies that I was able to find where they've actually tried to sample patient preferences. The Layman study is interesting. It involves a one-time telephone survey of a population-based sample of 200 women who were asked about their feelings on duty to warn in a range of different situations. 100% believed patients should tell at-risk family members regarding the risk for preventable genetic diseases. 97% believed patients should tell at-risk family members regarding the risk for developing familial breast cancer. 85% believe the patient should tell at-risk family members regarding their risk for developing non-preventable disease. Less than 25% believe that physicians should seek out and inform at-risk relatives against the patient's wishes. So clearly we're seeing a strong preference to place the duty to inform on the patient, not on the provider. And in the Plantiga study, we see that an overwhelming majority of patients surveyed across a range of disease groups that involve both genetic diseases and non-genetic diseases believe family members have the responsibility to share information on hereditary diseases, but not providers. Only a small minority felt providers should have that duty. In contrast to patients' preferences regarding the duty, we see some suggestion in the literature that patients' actions do not always mirror this preference. We have the case study that we talked about at the outside. We also have a study where medical geneticists were surveyed, and 60% reported patients who refused to warn at-risk family members. What would be the reason for some of the limitations in the consensus position that we should impose this duty to warn on family members? Well, as Dr. Stapleton said this morning, there is a scarcity of physician geneticists and genetic counselors who have the degree of education and experience to adequately counsel patients regarding shared family risk and regarding the nuances between preventable and non-preventable genetic disease. There is also a lack of resources to improve the counseling, improve access to counseling. Patient resistance comes from a variety of perspectives. First of all, patients might not have any contact with their relatives. Patients might have a desire to protect relatives from worry, from concern, and also there are strong individual autonomy preferences that some patients have or that might be reflected in family dynamics. And there was some discussion this morning about the right not to know, along with the right to control when I'm going to find out and who I'm going to tell. Now, having looked briefly at what the literature might suggest to the courts about a duty, let's look at the law, the available precedent that the courts would draw on. And it has to do with this notion of individual rights to privacy and what protections are there in the law. Well, there are constitutional protections, although interestingly, there is no clearly defined constitutional right to privacy of medical information. Although federal district courts and courts of appeal have variably recognized privacy rights, the Supreme Court has said that the extent of these rights will always give way to concerns about public health and public safety. Now, there are federal statutes which most of you, I'm sure, are familiar with, the HIPAA and the HIPAA Privacy Rule, as well as the new Genetic Information Non-Discrimination Act, which incorporates, by reference, some of the HIPAA privacy protections. Federal statutes set a floor on privacy issues, though. States have the ability to enact more stringent protections, and there are a range of state statutes that bear on the issue of patient confidentiality. There are comprehensive health care information privacy statutes. There are disease-specific statutes, such as statutes that provide heightened protection to health care information pertaining to mental health status or to HIV status. There are professional licensing and practice statutes that help define and shape a provider's obligation to protect confidentiality. There are also evidentiary privilege statutes. The physician-patient privilege is defined by the rules of evidence that influence what kinds of information will come into play in a lawsuit or in a court of law. And in some states, there are specific genetic privacy statutes, and the National Conference of State Legislatures does provide an updated database if you want to find out specifically where those statutes are in existence. There's also the common law. The common law is judge-made law. It arises when judges look at cases and resolve disputes by applying precedent, statutes, and earlier court opinions to a specific set of facts. And that shapes the common law. And two particular common law causes of action or theories of liability that we see in relationship to duty to warn issues would be invasion of privacy and breach of a duty to maintain confidentiality. All of these different sources of law demonstrate on careful analysis that legal rights to privacy are not absolute. HIPAA recognizes an exception to disclosing private health information without a patient's consent if it is necessary to prevent or lessen a serious and imminent threat to health and safety. And you're all very familiar, I'm sure, with the various public health mandates that require reporting when you suspect child abuse in certain infectious disease contexts and in a variety of other situations. Now, what about the duty to warn family members in particular? There are a series of cases that appear to be moving the courts toward defining an ever clearer duty to warn. And these cases started with the Tarasov case. In 1969, a patient by the last name of Podar killed Tatiana Tarasov 2 months after confiding to his psychologist that he intended to do so. This act of violence, which tragically ended Tatiana's life, also, for the first time, sharply focused the court's attention on the issue of duty to warn and under what circumstances should a provider be legally obligated to breach confidentiality to protect the health or welfare of someone who was not his patient. In evaluating the parent's claim, when they sued the psychologist, Dr. Moore, and his employer, alleging that Dr. Moore should have warned Tatiana and her family, and that had he done so, she would still be alive, the court looked very carefully at patients' right to privacy and confidentiality and the importance of confidentiality to the success of the treatment relationship, and concluded that public policy favoring confidentiality must yield to the extent the disclosure is essential to avert danger to others. Now, I've put up 2 other cases because they play with different requirements around this duty to warn. In Bradshaw versus Daniel, the provider who was sued had taken care of an individual who came into the emergency clinic with Rocky Mountain spotted fever. It's not an infectious disease per se, it's a disease that's contracted because of an infection that a tick transmits through a bite. And the man who came into the emergency room died. Several weeks later, his wife died of Rocky Mountain spotted fever, and the son sued the emergency room physician saying, "You should have told my mother the cause of my father's death, and that his condition posed a risk to other people who were in close contact with him." And the court said, well, now wait a minute, this is not exactly this is not an infectious disease. The the risk to contract is not quite as clearly defined as in other cases where we may have looked at this issue, but there is, based on the medical testimony and the medical evidence, a phenomenon here known as clustering. These Rocky Mountain spotted fever cases cluster, which suggests that where there is one person who contracts this disease, there is a risk to other people who may have had the same pattern of exposure to ticks that the, if you will, proband did. And so we're going to say in this case that the doctor should have realized that there was a risk to foreseeable people, i.e. family members, other people who may have been engaged in the same activities, and should have warned those family members, because had they known, they could have undertaken interventions that would have prevented the death of the mother. So there was an affirmative duty to warn identifiable third persons in the patient's immediate family against foreseeable risks emanating from the patient's illness. Reisner versus the Regents of University of California is an HIV case. A young girl contracts HIV through a needle stick in the hospital. And when she grows up and is mature, she becomes involved with a young man. At that point in time, she has full-blown AIDS. She dies. The young man has contracted HIV through his contact with this girl, and he goes on to develop full-blown AIDS and dies. And his family sues the original providers who were taking care of this girl after she contracted HIV in the hospital and said, you had a duty to warn. And the issue in that case was, well, now wait a minute. At the time that she contracted HIV, there was no identifiable third party who was at risk. And the court said, it doesn't matter whether the third party is identifiable. All they have to be is foreseeable. And it is foreseeable that this young girl would mature, would become intimately involved, and you should have warned. Now, you could not have warned him. You can discharge that duty by counseling your patient about the shared risk that people who come in contact with her have and what needs to be done to minimize their risk. So what we get from these cases in the non-genetic setting are a series of criteria that trigger a duty to warn and a range of ways or two choices for discharging it. You have to have a known or foreseeable person who is at risk for a serious health outcome stemming from your patient's condition, and that outcome can be avoided by disclosing or advising the patient to disclose protected health information. Now let's move to applications in the realm of genetic testing. And there's really three cases that have looked at applications of the law around duty to warn to shared family risk. The first case is Pate versus Threlkeld. This case involves familial medullary thyroid cancer, which is an autosomal dominant cancer for which genetic testing provides a clear medical indication for prophylactic or curative therapy. You can undergo a prophylactic thyroidectomy followed by thyroid hormone replacement therapy. In the absence of an early diagnosis and prophylactic treatment, a patient who carries this genetic condition is at high risk for developing aggressive cancer with very limited therapeutic options because most of these screening methodologies do not detect the presence of disease until the cancer is in an advanced stage. So here in 1987, we have a mother who receives diagnosis for medullary thyroid cancer. In 1990, her daughter is diagnosed with this same condition at an advanced stage. The daughter sues the mother's provider, alleging that the doctors knew or should have known there was a likelihood her mother's disease was genetic. They should have warned the mother of the shared familial risk associated with her disease and counseled her to tell her children about this risk and to encourage them to be tested. And had she been tested and diagnosed at an earlier stage, her outcome would have been very different. Now, this case is often referred to in the medical literature as one of two cases that really imposes a duty to warn on physicians, but does so in a way that creates a conflict or confusion for providers. In this case, the court said, there is a duty to warn. It depends on the prevailing standard of care. What is out there in terms of what doctors are supposed to know, what doctors are supposed to do in terms of diagnosing the genetic basis of conditions, and what is the prevailing standard of care regarding informed consent. They also recognized that ordinarily, meaning in most situations, you can expect the patient to pass on the warning. And they emphasized that if there is a duty of care, it can be discharged by warning the patient. The other case that is often referenced in the medical literature as creating a conflict for providers because it reaches a different conclusion is Safer versus Pack. And I'm actually going to share with you my opinion that the court came down in substantially the same way. Here we have, as a fact pattern, a father treated in the 1950s and 1960s for multiple polyposis of the colon, which progresses to full-blown retroperitoneal cancer. Ultimately, he dies of metastatic disease involving his liver. In February of 1990, his daughter, then age 36, is diagnosed with a cancerous blockage of the colon and multiple polyposis. She undergoes a total colectomy with an ileorectal anastomosis and oophorectomy involving the left ovary. She has extensive follow-up chemotherapy. Once her therapy is completed, she and her husband sue the estate of the now dead provider who took care of her father, alleging that her condition was a hereditary condition. It was the same condition her father had, and that had it been discovered and treated earlier, she would have been in a much better position in terms of her own health. And she argued that the standard of care at the time her father was treated required physicians to determine whether the condition was hereditary and to counsel family members of shared risk. Or if not determine, if not test, given the state of testing back then, to at least advise the patient and and their family about the potential for shared family risk. Now, the court acknowledged in resolving these issues and looking at this case that there was a duty to providers, and that duty could, in certain circumstances, which the court really didn't define, warn family members, could require that the provider warn family members directly. However, what it did was it said, we don't know enough in this case to know whether there was a breach of duty or not. We don't know yet what the conversations were between the provider and the father and the mother, and we need a lot more information before we decide in this case that this doctor had a duty to breach patient confidentiality and warn these family members. And so the court remanded the case to the trial level to figure out and discover more facts. And interestingly, in response to this case, out of a, I guess, particular concern that it would be cited for the proposition that providers always have a duty to breach confidentiality and warn family members, the New Jersey State Legislature quickly passed the New Jersey Genetic Privacy Act, which would prevent providers under the law from disclosing confidential genetic information regarding their patient to anyone absent the patient's consent. Now, the last case that is sometimes referenced in the literature has a little bit more relevance to the pediatric population, and that is Malloy versus Meyer. And the fact pattern involves Kimberly Malloy, who, when her daughter, who's referred to in the case as SF, was 3 years old, had her evaluated by Dr. Meyer because she was exhibiting developmental delays and because she had a mentally retarded brother, a half-brother. Dr. Meyer recommended genetic testing, and while she did not specifically discuss testing for Fragile X with Mrs. Malloy and her then husband, her notes reflected that she considered the possibility of this diagnosis, and certainly the expert testimony in the case established that it would have been the standard of care for providers at that time to consider Fragile X and recommend testing for that condition. Genetic test results came back as negative. Unfortunately, those tests did not include chromosomal testing for Fragile X, although the mother was never told that. In 1998, Kimberly Malloy gave birth to MM, another child, who exhibited the same developmental delays as SF. MM's pediatrician ordered Fragile X testing, which was positive. Mrs. Malloy sued the original pediatrician who had taken care of SF when she was 3 and ordered the original round of genetic tests, and on the theory that you had a duty, provider, to talk to me about the potential implications of genetic testing and this concept of shared family risk, and that whatever was going on with my daughter, and in particular the risk of Fragile X, but that whatever was going on with my daughter, it could be passed to subsequent children. And that would have informed my reproductive decision making. Now, this is a little bit different fact pattern than Pate and Safer and some of the other duty to warn cases we talked about, because it really is involving a minor child who is the patient and the parent. And the court really said in this case, biologic parents do have a right to know, and they should be informed. They should be warned about the genetic hereditary implications of any conditions that their children have. But the court specifically limited their discussion around duty to say that we do not address whether the duty recognized here extends beyond warning the biologic parents of a pediatric patient who the doctor is taking care of. So, what do we learn from the law? We learn that actually the duty, in my opinion, the duty as defined in the law very closely mirrors the consensus position that is taken in the literature, and that is that a duty to warn arises in a very narrow set of circumstances where you have a highly penetrant genetic disease with a fairly well-defined and consistent pattern of severe expression. You have available treatment that, if timely administered, and it is time-sensitive, prevents or significantly minimizes the extent of the adverse health outcome. And you have identifiable or foreseeable family members. You resolve whether there is a duty in the law by looking at prevailing scientific evidence and clinical practice, and in almost all cases, this duty to warn is going to be discharged by counseling the patient and encouraging them, with full education of the significance of their condition, to talk with potentially affected family members about shared family risk. So let's go back to the case report. What did the providers do? They made the decision not to breach patient confidentiality and tell the family members about the correct diagnosis after considering the following factors. Family members other than the proband's offspring were already aware of the shared genetic risk because of the testing that they had undertaken. As to the children, the data regarding benefits of routine screening and prevention options for BRCA1 mutation carriers was still emerging at that point in time, and there was not clearly defined time-sensitive treatment that would make a difference if the daughter were to have the mutation. In addition, at 23, she was still then too young to begin any mutation-related surveillance that would be recommended. And finally, after counseling this proband on repeated occasions, they obtained an agreement that they would maintain periodic contact, that they would revisit issues around disclosure, and a commitment from the patient that she intended to take care of her offspring and would make a timely disclosure. So what recommendations come from the perspective of the law? I think the first is to be very careful in your research, in your literature, and in your discussions around this topic of duty to warn, to extend the duty beyond the scope that it presently has. Because the courts do look to professional statements, and they do look to the literature to see how our providers who are in this position and have far more expertise regarding these conditions than we do define the scope of the duty. And instead of spending a lot of time talking about whether there should be a duty to warn, to breach confidentiality, to reach out to family members, focus on developing resources and expanding the base of education so that patients can receive the adequate counseling they need to fully understand the implications of shared family risk. That will help them make the right decision. It will help them keep these discussions within the family and allow the family to make the decision. Thank you.